Given time is 6 minutes. Please try to wind up within that.
Shall I start? Good morning, everyone. I'm going to present my study on use of topical insulin to treat refractory neurotrophic corneal ulcer. To begin with, neurotrophic keratopathy or corneal ulcer is a rare degenerative condition characterized by decreased innervation of the cornea, causing epithelial breakdown and poor wound healing. It affects less than 1.6 per 10,000 of people. Treatment options include lubrication alone to multimodality management, including aggressive topical and surgical treatment. Now, a neurotrophic keratopathy becomes refractory when it is unresponsive to conventional treatment. And nowadays, studies on topical insulin shows that in low concentrations, it is a promoter of cell migration, it stabilizes corneal enzymes and regulates its biological environment, and is also safe for topical ocular use in humans. So, the aim of our study was to evaluate the efficacy of topical insulin drops in treatment of refractory neurotrophic keratitis and to analyze how it may improve epithelialization. So it was a prospective, non-randomized, interventional, hospital-based study on 8 patients visiting a tertiary eye center. It was done between August 2021 to February 22, and neurotrophic keratitis unresponsive to medical treatment were included in our study, whereas those resulting into corneal melt or perforation were excluded from our study. So how we had prepared topical insulin drop? It was prepared by mixing regular insulin in artificial tear with polyethylene glycol and propylene glycol base at a concentration of 1 international unit per ml by a sterile technique, and topical insulin drop was prescribed 4 times daily and bandage contact lens was applied. The measurement of persistent epithelial defect area was done. The treatment was continued until persistent epithelial defect or ulcer resolved and was tapered accordingly. So patients' demographics, NK etiology, concomitant treatments, and comorbidities were reviewed. Approval was taken from Institutional Ethics Committee, and the tenets of Declaration of Helsinki were followed. So coming to result, we had 8 patients, 3 of which were females and 5 were males, with a mean age of around 52.75 years. The comorbidities included herpetic eye disease in 3 of the patients, chemical injury in 1 patient, lag ophthalmos in 1 patient, uncontrolled diabetes mellitus in 1 patient, and past history of ocular surgery in 2 of the patients. The eye of 7 patients, that is 87.5%, had reepithelialized, and 1 patient still presented with an epithelial defect, although it had decreased in size. The mean persistent epithelial defect area before treatment was 15.87 millimeters square, which reduced to around 1.1 millimeters square after treatment. The range before was 3.75 millimeters square to 32.5 millimeters square. The mean area in reduction of persistent epithelial defect area was around 93.7%, which is quite significant, and as shown in the line diagram. Now, the mean time until reepithelialization was 13.375 days, which ranged from 7 to 21 days. No side effects were reported during treatment. As we can see in the diagram, 2 of the cases, in case 1, complete reepithelialization was seen by day 14, whereas in case 2, it was seen by day 21 of treatment. Now, we know insulin-like growth factor 1 or IGF-1 is an important modulator of corneal wound healing. In several preclinical studies, IGF-1 acted synergistically with substance P to promote corneal epithelial wound healing. The presence of insulin receptors on cornea and lacrimal gland and increased prevalence of keratopathy in diabetic patients suggests that insulin may contribute to corneal wound healing. And N.K. Wang et al. Described topical insulin for sterile refractory neurotrophic ulcers from various pathologies that reepithelize within 25 days after starting topical insulin drops 2 to 3 times daily. Galvez et al. Described a case of exposure keratopathy that progressed to an infected neurotrophic ulcer after acoustic neuroma resection. Topical insulin, 1 international unit per ml, was used as an adjunctive therapy to topical antibiotics. Besson and Link suggested that 50 international unit per ml topical insulin might improve the rate of epithelial wound healing, whereas Phi et al. Found that 25 international unit per ml was associated with better healing. So they had used a higher concentration as compared to our study. Now, the limitations of our study was heterogeneity in the patient presentations, differences in treatment duration, and lack of a comparative control. To conclude, topical insulin may be a simple and effective treatment for refractory neurotrophic corneal ulcers, and additional advantages are also there, like excellent tolerance, availability, and cost effectiveness. Thank you.
Thank you, Dr. Suchitra. Any questions on the panels?
What is the shelf life of these drops, and how do you store them?
Pardon, sir?
Shelf life of the drops which you made.
We had refrigerated it. We used to keep it in refrigerator for 1 month. We didn't use it after 1 month.
Okay.
Okay.
Which insulin?
Ma'am, Act Rapid. The insulin injection we had used. If we had 3 ml bottle of PEG and PG drops, we used to put 3 units of international unit by the pen.
Okay, I have two questions. One, you did not classify the neurotrophic keratitis initially. You had only 7 or 8 patients. So were they of which class? There is a METI classification, if I remember.
They mostly came to us when it was in stage 2. Stage 3 were excluded from our
Okay,
study.
you didn't take stage 1. You went for stage 2 and stage 3.
Mostly they were in stage 2. So stage 3 were
Okay.
already excluded,
Okay.
and stage 1 they didn't know they had. They came to us in stage 2 only.
Okay,
Sir.
okay, that is one. Second, similar studies were already published. So what is the new message you are giving?
So actually, I wanted to see the results in our area.
Anything
Not
different from
my
the previous study? There is another study, I think 17 or 18 by Wang et al. That you were mentioning.
Yes, I have seen. So I
Okay.
didn't see similar study in around. I didn't see like.
What is the difference? What was the difference in this study from that?
So like this works in poor peripheral areas where we can't use serum, autologous serum eye drops or AMT and other procedures. We can use topical insulin in those areas.
Okay.
Like ours, we can't do AMT and the other serum eye drops for poor patients also. Like topical insulin is affordable for them and it's like easily accessible. We can do that. So we can use that for those patients.
Okay, well done.
Thank you.